Respiratory system review, as simple as possible, awkwardly simple anatomy and physiology. And this is our second review. Last time we talked about the plumbing, the passageway, the vents, so to speak, that got the air down there where you can begin to start exchanging respiratory gases between the air and the blood. This time, let's say something about the mechanisms that actually cause the air to move in and out, particularly in the conducting zone. Now, this strangely simplified picture right here is supposed to represent the outside environment, the outside atmosphere. Here is the upper respiratory tract. Let's say it's the trachea, comes down here to primary bronchi, and then goes into a lung. Now, we're not talking about right and left lung here. We're just talking about the inhalation story versus the exhalation story. But let's look at the picture real quick. Around the lung, there is a pleura. Now, the pleura represents the serous membrane that is adhered to the surface of the lungs, but also forms an outer wall. So this would be the visceral pleura, and this out here would be the parietal pleura. Between the two would be the pleural cavity, and there would be serous fluid in this space right here. In another review, we'll talk about the adhesion and cohesion of the fluid in here and how a pulling force is able to be transferred from the visceral pleura through that fluid to the, from the parietal pleura through that fluid to the visceral pleura and then to the lung tissue itself, the stroma of the lung tissue itself. But right now, let's look at the forces involved. So there is pressure outside the body, and let's say for convenience sake, it's 760 millimeters of mercury, a standard air pressure at sea level in a standard normal day. Well, the pressure inside the alveoli, the open air sacs of the lungs, should be the same as the pressure outside, unless you're changing the size of these air sacs. By expanding or contracting them, you can cause the pressure to change. And what's most important right here is the fact that we're going to compare the pressure inside the air sacs, the alveoli, to the pressure of the atmosphere. We know that fluids tend to move from high pressure to low pressure. They move down their gradients from high to low. So we can make the pressure inside this air sac right here higher than the pressure outside. Air will leave the air sacs and go to the outside. We'd call that exhalation or expiring. If, however, we can make the air pressure inside the alveoli, the air sacs, lower than the pressure outside, then air would go from greater to lesser, and the air would rush in to these spaces right here, and that would be inhalation or inspiration. So, to exhale is to make the pressure inside your alveoli greater than the outside atmosphere, and to inhale is to make the pressure inside the alveoli less than the outside atmosphere. Now, there is that's called intrapulmonary pressure, by the way, the air pressure inside the alveoli. Now, in the pleural space, that's called intrapleural pressure. And a strange thing right here is the intrapleural pressure must be lower than the intrapulmonary pressure. As we'll point out later on when we talk about the pleural fluid and how through adhesion and cohesion you can keep the lung expanded and how you can push and pull through that fluid. Suffice to say that the integrity of this space right here and of that number right there makes breathing in and out possible. And this number, the intrapleural pressure, must always be lower than the intrapulmonary pressure to keep the lung from collapsing onto itself. More about that later. So, over here, during exhalation, the intrapulmonary pressure will be greater than the atmospheric pressure. Air goes out. The intrapleural pressure is less than the intrapulmonary. Over here, during inhalation, the alveolar air pressure, the intrapulmonary air pressure, is less than the atmospheric air pressure. The air rushes inside. But still, the intrapleural pressure must be lower than the intrapulmonary pressure. It's an absolute. Now, as far as how do you make these things get bigger or smaller, well, it's all about Boyles Law. And Boyles Law basically says if you can make a cavity larger, the pressure of an enclosed fluid of that cavity goes down. If you can make a container smaller, the pressure of an enclosed fluid in that container goes up. So this is all about expanding the lungs, and this is all about collapsing or squeezing the lungs. The way that this is possible is through the actions of the diaphragm and the actions of the intercostal muscles. Generally speaking, the diaphragm acts like a piston inside of a cylinder. When you contract your diaphragm, the diaphragm, which is normally domed shape, tends to flatten a bit and drop down, thus making the floor of the thoracic cavity drop down and the thoracic cavity become larger. So the volume of the thoracic cavity went up because the diaphragm went down. Well, if you allow the diaphragm to relax, it would move back up into its domed position, and by doing so, it would make your thoracic cavity smaller. Because the volume of the thoracic cavity became smaller, the pressure of the enclosed gas became larger. So this is the primary mechanism by which you invite air to rush in to this lower air pressure, and then you push the air out. An important thing right here is that you do not suck air in on inhalation. You cannot pull air. All you can do is try to provide a space where there's lower air pressure and invite the atmosphere to rush inside. We can say things about how a vacuum cleaner does not suck air inside. It creates a low air pressure space and allows the atmosphere in your room that you're vacuuming to push materials into the vacuum cleaner. It's a strange backwards way of saying it. Well, another set of muscles that are involved in inhalation and exhalation, making your chest bigger or smaller, are the intercostal muscles. And the external intercostal muscles, which are found between the ribs, are angled in such a way that when they contract, they cause the ribs to move up and out. It's like you're lifting the handle of a bucket. When you lift the handle of a bucket, after it's hanging on the side of the bucket, the handle has to go out to go up, and the ribs do that too. So by contracting the external intercostal muscles, you cause your rib cage to move up and out, and that also allows the chest to become larger, the pressure inside to become less, and it invites the atmosphere to rush inside. So by dropping your diaphragm and lifting your ribs up and out, you make your chest larger, the air pressure inside lower, and there the atmosphere rushes in. When you relax the external intercostals, the ribs go back down to their normal position, which means they go in and down, and that makes the space smaller inside your chest, and that will cause the pressure inside to increase, and that also helps you push the air out. If you think about a maximum inhalation and a maximum exhalation, you take advantage of this voluntarily, consciously, to make your chest as big as possible and to make your chest as small as possible. Once again, a review when it comes to numbers. These are relative numbers compared to the atmosphere at approximately 760. If the pressure inside the lung is greater, that's exhalation. If the pressure inside the lung is less, that is inhalation. But always remember, the intrapleural pressure will always be lower than the intrapulmonary. This is the thing that allows the lungs to stay inflated even when you exhale.